A salivary gland duct stricture is a narrowing or blockage of duct that carries saliva from salivary gland to the mouth. It can cause various symptoms including dry mouth, swelling, pain. So, most common duct obstruction or stricture is parotid gland, followed by submental gland, and followed by sublingual, and lastly, very rarely involved, minor salivary gland. The common causes of stricture are inflammation, trauma, stones, and anatomical abnormality in the duct system. So these four causes are common for development of the narrowing or stricture of the duct of the salivary gland. The salivary duct structure can be classified based on various factors including its location, cause, severity. So if you see according to location, it is intraoral stricture or extraoral stricture. Causes mainly inflammatory stricture resulting from chronic inflammation such as chronic sialoadenitis, or it may be because of infection or autoimmune. Second cause may be traumatic stricture caused by physical injury or damage to the ducts. Obstructive structure may be typically due to presence of salivary stones, siloliths, or other obstruction within the duct like debris. Idiopathic stricture because it may be because of unknown cause. Severity, if you say mild stricture, partially narrowing of duct within the minimal symptoms. Moderate stricture, significant narrowing of the duct leading to noticeable symptoms. And severe stricture, near complete or complete blockage of duct resulting in severe symptoms like pain and swelling. The classification of salivary duct stenosis or stricture. According to University of Iowa Silogram classification, or you can say grading scale, it is three types. First degree, it means main duct obstruction. Main duct means primary duct obstruction. It is from the proximal segment of the duct to the oral cavity, means major bifurcation is obstruction. Second degree is segment of duct proximal to first major bifurcation or distal to second obstruction is strictured. Third degree, any duct proximal to second bifurcation including of small branches, means quaternary divisions are obstructed. It means main duct obstruction is grade 1. The second bifurcation and secondary divisions are second degree obstruction, and third degree minor or small branches obstruction is called third degree division. You can see this picture. Between distal to first primary bifurcation is first degree duct is obstruction. Between first degree to second degree obstruction and third degree is beyond third degree obstruction is called third degree obstruction of these small branches. Another system adopted from Foggy et al. And Thorpe et al. These classification according to location of the stenosis. Score 0 means no stenosis. 1 is tertiary quaternary duct obstruction. Second is secondary duct obstruction. Third is third main duct obstruction. According to the percentage degree of stenosis, means no stenosis 0, minimum less than 25% stenosis grade 1, 25 to 50% obstruction stenotic segment is grade 2, 50 to 75% is grade 3, and more than 75% stenotic segment is there, it means grade 4. So these are various Foggy, Thorpe et al. Classification for stricture or stenosis of the salivary duct. Two main investigation to diagnose this stricture. First is MR xylogram. Second one is digital subduction xylography. So these both techniques are equivalent to each other to diagnose the stenotic or stricture. Overall, digital subduction xylography continue to be the standard technique for imaging the extra or intraglandular duct system. If acute sialoadenitis is present in or insertion of cannula is difficult or not possible, Then non-invasive MR silography provide an excellent alternative of ductal system anatomy. Treatment of salivary duct stricture depend on severity, location, underlying cause of stricture. So first treatment is conservative management. You have to hydrate the patient properly and massaging the affected gland to help the clear the stricture. Second is minimal invasive technique like duct dilatation, stent placement, and salivary gland endoscopy can be helpful to dilate the stenotic segment. Third one is surgical intervention. If severe stricture is there and multiple involved, you can remove the gland, or you can do duct relocation if you can bypass the duct stricture. You can do siloendoscopy to remove the particular cause, or you can dilate by the duct which is non-functional, and you can remove the non-functional gland. Physical therapy, you can enhance the jaw exercise and oral massaging, and so these treatment basically depend on underlying therapy.